Welcome, everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. Quick footnote, I have been on active surveillance since 2009, and I'm still a member of my local support group that got me started on this journey. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment but a management plan. I would like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. ASPI supports the concept of the proactive patient who's interested in reading materials, watching videos as part of their research, participating in support groups, attends, if possible, relevant conferences, and most importantly, establishes decision-sharing relationships with their doctors. We are not here to dispense with any medical advice. Nothing said during our meeting by our speaker, ASPI, or the audience should take the place of consultations with your medical professionals. A couple quick housekeeping measures. We are going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. And please keep your questions limited in scope. The doctor does not have time to review your case history. At that time, you can also click the raise hand button from the bottom of the Zoom window toolbar, and if there's time, we'll try and call on you. Also, please keep yourself muted during the meeting. The speaker presenting here today is generously donating his time, so we want to be respectful of that. Also, you do not need to take notes during the talk as this meeting is being recorded and will be available on our website in approximately 1 week. You will get an email notifying you when it's ready. Also, if you want to subscribe to our YouTube channel, you will automatically be notified when a new video is posted. So, without further ado, we'll have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest speaker. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Mark.
This is Saturday Sanctuary for active surveillance patients, and we hope you might find some peace in this moment on Saturday. I um, I I had a stroke 2 years ago, so I have no notes. I do want to say something about Active Surveillance Patients International. We are doing some amazing things, and with your support, without your support, we don't do them. So we need your continued support. But one of the most exciting things that I think we have available now is shorts, short films, 1 minute films, searchable films. So if you have a topic, whether it's PSA, whether it's radiation, whatever the topic, you can search our short films. Nobody else has this, only us. And we realized that many men would not have the patience to sit through a whole webinar. And so we decided that you needed this. And we've gotten wonderful feedback on it. And the other thing, where else we need your support is also we are going to be coming out with an ebook on active surveillance, and this is going to be the most thorough ebook available because we know more about active surveillance than any other group. We're patient-led, and there's a lot of knowledge right here with us. I wanted to mention too, we also have a cavemen program, which is exciting, and that's was launched, but it's going to be relaunched in another few weeks, we think, and that's a wonderful support group for you folks. So um, those are things that you can only get through us and only happen with your support. And with that, I want to introduce Howard Walensky. Howard?
Well, thanks, Mark. Thanks, Bill, and welcome everybody. I suppose I should say I'm coming up to my 15th anniversary on active surveillance and thinking of doing a celebration like they do for the young ladies in the Mexican culture for the 15th. So keep looking for it. I'm here to welcome Dr. Darryl Leong. He's a distinguished cardio-oncologist based in Hamilton, Ontario, Canada. He holds the position of scientist at the Population Health Research Institute and serves as director of the McMaster University and Hamilton Health Sciences Cardio-Oncology Program. He is a graduate of the University of Adelaide Medical School. He furthered his education at the same institution, completing his cardiology training, as well as earning a Doctor of Philosophy, a Master's of Public Health, and a Master's of Biostatistics. It's a lot of doctor in Darryl Leong. He then pursued postgraduate training in cardiovascular imaging in the Netherlands. Dr. Leong's research focuses on the intersection of cardiology and oncology, with support from prominent organizations such as the Canadian Institutes of Health Research and the Canadian Cancer Society. So, Dr. Leong, the floor is yours.
Thank you very much, Howard, Mark, and Bill, for the kind invitation. It's a real privilege and honor to be spending some time with you today. I'm going to share my screen now, so bear with me while I do that. Okay, so I think you should be seeing the slides that I'm going to speak to, but of course this is a discussion and a forum where we would encourage at the right time interaction, and we can certainly expand on anything we present today. Howard assured me that you are a very well-educated and informed group. And so the level that these slides and information is pitched at is what I would deliver to healthcare professionals. But if anything needs clarification, feel free, even in the chat, and I've got my eye on that, and we can certainly try and clarify anything that needs clarification. I do provide advice and consultancy to a number of pharmaceutical companies that produce compounds to treat prostate cancer, and I've given a number of talks and serve on a number of steering committees and committees for these companies. So if you only want to see one slide, here are my key messages that I want to hope you can take away today. Firstly, that cardiovascular disease, including things like heart attacks, strokes, heart failure that can result from heart attacks or result from hypertension, these are common and they're important if you have prostate cancer. Risk factors for cardiovascular disease like obesity, diabetes, hypertension are also common and generally are suboptimally controlled, at least in Canada and in several other countries around the world. Hormonal therapy for prostate cancer has important side effects when it comes to cardiovascular risk factors. And we really need to do more research, I feel, to identify ways to reduce the impact of cardiovascular risk factors and disease on people with prostate cancer. So why should a cardiologist be interested in, prostate cancer? Seems a little far removed geographically within the human body. These are data from the United States, from the SEER registry that I'm sure you've heard of. Over 700,000 men with localized prostate cancer, and it shows you on the graph here the causes of death in different colors. You see the proportion of deaths due to cardiac disease appropriately in the reddish sort of maroon color, and the proportion of deaths actually due to the prostate cancer in the blue. And what you'll appreciate is that at all times after diagnosis, the chances of someone with prostate cancer dying of cardiac disease is actually higher than the chances of dying from the cancer itself. So many of my patients are surprised when I tell them that piece of information, that actually what they were diagnosed with originally may be not their leading cause of death. And even in folks with metastatic prostate cancer, That figure of 1.48 you can see on the slide there indicates that you're almost 50% higher risk of dying of cardiovascular disease than men without prostate cancer. I'm just going to bring up the Zoom page again because I seem to have lost everyone. There we go. So that's why we feel that cardiovascular disease is relevant in prostate cancer communities. If you take the lens of a cardiologist, we consider that your risk of developing heart disease in the next year to be high if we estimate, based on a number of factors, that risk is at over 2% per year. Or put another way, if over the next 10 years of your life, if you've got a 20% or a 1 in 5 chance of developing cardiovascular disease, we consider you a high-risk individual. So here are the numbers for folks with prostate cancer. This is Swedish data, but there are similar data from US as well. And it shows you the rate of cardiovascular disease developing per year before versus after starting androgen deprivation therapy. And those cardiovascular diseases are broken up into the main ones. So coronary heart disease or ischemic heart disease, I guess most typified by heart attacks, heart failure I mentioned before, and strokes. What you'll appreciate is that if you were to tally up these rates of cardiovascular disease, they clearly tally up to more than 2% per year. So we're talking about a high-risk population here in Sweden. And within the couple of years after initiating hormonal therapy, that cardiovascular risk appears to rise even further if you follow the arrows, and clearly is well more than 2% per year. So certainly a lot of evidence that this is a high-risk group. So why is this? We tried to understand why folks with prostate cancer did have or were at high risk of developing cardiovascular disease. If you look on the right-hand graph, you'll see the rates of cardiovascular disease represented by the bars, both in patients on and those not on hormonal therapy. And you'll see in the tallest column that at least 20%, so at least 1 in 5 individuals with prostate cancer had cardiovascular disease even when they were diagnosed with prostate cancer. So you're starting off from a risky baseline, many individuals. The specific types of cardiovascular disease are shown in the smaller columns here, heart attack being the most common, of course, but cerebrovascular disease or stroke also being important, atrial fibrillation, heart failure, and peripheral arterial disease. When we talk about risk factors for cardiovascular disease on the left, we see that those are also very common in men with prostate cancer. In particular, high cholesterol and a history of smoking are common. High blood pressure is common, as is obesity and diabetes. And so the risk level, which we measure in this case by the Framingham score that you may have heard of, is very high in a lot of people. So this is part of the story, I think, as to why cardiovascular disease is so prominent in folks with prostate cancer, is that they're starting off by virtue of typically being men in latter decades, being at high cardiovascular risk. How well are these risk factors being treated? Here is data from 90,000 US veterans that was analyzed by my friend from the University of Pennsylvania, Dr. Bonnie Key, and her group. What you can see is the target blood pressure, cholesterol, and glucose levels, which are, fairly widely accepted, although fairly liberal targets, I would say. And she found that at least 1 in 3 men with veterans, I should say, with prostate cancer did not have blood pressure that was satisfactory. At least 1 in 5 did not have cholesterol levels that was satisfactory, and almost 1 in 5 had poor blood glucose levels. That tells us that cardiovascular risk factors are not being well attended in these individuals. Now, I mentioned that these targets that Dr. Bonnie Key used are fairly liberal. And the reason for that is that if you actually have diabetes or you have cardiovascular disease, the guidelines in the United States now recommend even more aggressive target blood pressures and cholesterol levels than what are indicated on this screen. So we took these guidelines and into a cohort of patients with prostate cancer that we've recruited from 4 countries, over 2,800 men, to look at how well these risk factors are controlled when you take into account what they should be according to current American guidelines. The big pie chart here shows you that about half of patients with prostate cancer have suboptimal control of most of their cardiovascular risk factors in the red part of the pie. And the particular risk factors that are not well controlled, you see on the left-hand side here, where almost everybody had a waist circumference that was bigger than what it should be according to guidelines. 3/4 of individuals' blood pressures were above what the guidelines would say should be the target, and 1/2 had cholesterol levels above target. 1 in 5, by their own report, would be considered physically inactive, and 1 in 10 were ongoing smokers despite being diagnosed with a cancer. So this tells us that risk factors are not being well attended, and you can see here that being frail in the top line was one of the strongest reasons why individuals did not have their risk factors adequately addressed. So this is, in my mind, low-hanging fruit and something that folks need to be aware of, healthcare providers and patients alike. A key question we always get asked is, does androgen deprivation therapy lead to cardiovascular disease? And here are my takeaways from the science. Many observational type studies would suggest that there is an association, somewhere between 10 and perhaps as much as 30% higher risk of developing cardiovascular disease if you're getting treated with androgen deprivation therapy as compared to folks with prostate cancer who don't get ADT. What we also know is very clearly, and we'll show you, ADT does worsen cardiovascular risk factors. We've done a lot of research to demonstrate that. Promisingly, I guess, and why we still use ADT liberally, is that the randomized controlled trials of ADT do not suggest that it increases cardiovascular death. So while ADT might in some ways predispose to heart attacks and strokes, the signal is not strong enough to translate, it seems, into an excess risk of cardiovascular death. Perhaps that's partly due to awareness, partly due to good levels of healthcare preventing heart attacks and strokes leading to death in many cases. But also, there are differences in the designs of these studies that might explain some of these differences and what you might consider divergent findings. What about, what risk factors does androgen deprivation therapy hit? This was some old work now from Dr. Matthew Smith, looking at only 26 men starting Leuprolide for their prostate cancer. He compared, in fact, what you can see is that weight and waist circumference seem to increase by, approximately 3% over the first 12 months. So that was some of, I would say, the earliest data and often quoted data to show the effects of androgen deprivation therapy or Leuprolide on adiposity. Now, we saw these data and we thought 26 is not a whole lot of individuals. Maybe we need to study this a little more robustly to be confident about these numbers. And we'll show you that our data later on. Here's a study of 100 individuals with prostate cancer, about a third of them treated with hormonal therapy, showing you the effects or the changes in muscle strength as measured by hand grip in these individuals. And you can see here that those who are treated with androgen deprivation therapy in the solid line exhibited this continuous decline, deterioration in their hand grip strength and in their muscle strength. Again, in our experience, not a large study, 100 individuals, and we wanted to confirm this a little more robustly. So that's what we did. We took over 2,000 individuals who were not treated with androgen deprivation therapy. These are all prostate cancer patients. Compared them with 1,700 individuals who were treated with hormonal therapy, and we show you the results here in these graphs. So the dashed lines represent folks who did not get hormonal therapy. The solid lines represent those who did. And what I show you is the change in physical measurements from baseline up to 1 year, okay, in each of these graphs. I've summarized the big findings in the text. So you can see in the top left graph that those who were treated with hormonal therapy had on average a 1.6% increase in body weight. They had a 2.2% increase in their waist circumference, but actually a similar extent of increase in hip circumference as well, a 1.6% increase. And so, the gain in waist to hip ratio, which we often measure, was less pronounced because both waist and hips were growing. What I think was even more profound than that, even though, the waist is perhaps what many men might notice first, is loss of strength. So in the bottom graph here, you can see that hand grip strength that was measured in 100 people in the previous study and in about 4,000 in our study decreased by a quarter. So a huge loss of muscle strength. And when we measured the ratio of each individual's strength relative to their body weight, that also decreased by about a quarter. Now, we weren't able to show that this loss of strength led to slowing in how fast folks could walk at 12 months. Of course, we're continuing to follow our participants up, and so we'll see what happens longer term in things like mobility in folks getting treated with androgen deprivation therapy. ADT predisposes to diabetes. Here are data from a large US study showing in the red curve, this is the accumulation, the cumulative number of individuals diagnosed with diabetes during several thousand days worth of follow-up. And those in the red curve on the top are those who were primarily treated or treated with androgen deprivation therapy up front. Those in the bottom curve were prostate cancer patients not receiving ADT. What the 1.61 tells us is that if you got ADT, you're at 60% or 61% to be exact, higher risk of developing diabetes during several years follow-up as compared to those who did not get treated with androgen deprivation therapy. We talk about hypertension, another important cardiovascular risk factor. Here are data from Taiwan showing, I guess, very similar graph. It's just kind of inverted for the purposes of presentation. But the folks getting treated with androgen deprivation therapy in the dotted line were at 78% higher risk of developing hypertension than patients with prostate cancer who did not receive ADT in the solid line. So similar, 60 to 80% higher risk of developing diabetes or hypertension. Now, muscle strength, I mentioned it before. This is how we measured it in our study using this kind of a device where you squeeze as hard as you can and the dial tells us how many pounds of force can be generated. And I would put it to you that this is really an under-recognized cardiovascular risk factor. We studied this in a multinational population, 140,000 adults from around the world. These were individuals mostly without prostate cancer. And so for every 5 kilogram lower hand grip strength, so about just over 10 pounds less in hand grip strength, we found a 7% higher risk of heart attack, a 9% higher risk of stroke, and a 17% higher risk of dying of cardiovascular disease in the next several years. And so clearly, muscle strength is an important risk marker for who is going to get cardiovascular disease and potentially die of cardiovascular disease. So this is the general adult population. How does this relate to folks with prostate cancer? These are the same sort of curves I've been presenting all along. This is our data again in about 4,000 adults with prostate cancer, some from the US, many from Canada. The horizontal lines represent time, and each of these colored curves represents the accumulation of cardiovascular events and cardiovascular disease in these individuals over 36 months, so 3 years worth of follow-up. The different curves, different colors represent quarters of the cohort. So if I can talk you through the top left graph, you'll see that quite interestingly, it didn't matter if you were in the highest or lowest category of body weight. There wasn't a profound relationship with the risk of developing cardiovascular disease during 3 years follow-up. Kind of interesting. But if you look at waist circumference in the top middle graph, and you look at the dashed black curve here, which clearly stands out from the rest of the pack, that tells us that if your waist circumference is higher than 3/4 of your peers, you seem to be at quite significantly higher risk of developing cardiovascular disease in the next 3 years. So waist circumference and also hip circumference seem to be stronger markers than just measuring body weight alone of developing cardiovascular disease. Look here in the bottom middle at hand grip strength measured using that squeezing dynamometer I showed the picture of before. An even more profound relationship with low muscle strength and the risk of developing cardiovascular disease. The group with the lowest muscle strength in the dashed line, so this is the lowest quarter. So it's not a small number of people. This is almost 1,000 people with low hand grip strength. They were at, look at the graph here, almost double the risk of developing cardiovascular disease as compared with those who are stronger. And even if you had, in second quarter for hand grip strength, the risk of cardiovascular disease was still higher. We looked also on the right-hand side here, and the bottom right, at how fast you can walk. This get up and go time is simply measured with a stopwatch. We asked participants to get up from a chair, walk 3 yards, turn around, walk back, and sit down again, and we measured that with a stopwatch. And you can see from the black curve here that if you were slow at doing that, if you were slower than 3/4 of other men with prostate cancer at doing that task, you were also at substantially high risk of developing cardiovascular disease during the next 3 years. So I think this is the biggest and a study that's been dedicated to men with prostate cancer to understand their risk factors for developing cardiovascular disease. And these are clearly physical traits and characteristics that tell us about risk. Now, I know, as I said before, you are an educated group, well-versed into the various hormonal therapies. But this is a schematic diagram you may have seen before about the different points within the body where the different forms of androgen deprivation therapy can act to either stop testosterone being synthesized or reduce the effects of androgens, including adrenal gland androgens, on the testosterone receptor, androgen receptors, and therefore the prostate cancer. So a lot of different therapeutic options now, which I think is great. Important differences in some of them. You will have heard, I think, of GnRH or LH-RH agonists, the most common form of androgen deprivation therapy, drugs like leuprolide, goserelin, etc. There are also GnRH antagonists. You might have heard of relugolix and degarelix. So both these different families of drugs work by interfering, I guess, with the part of the brain, the pituitary, that produces hormones to stimulate the testes to produce testosterone. They just do so in slightly different ways, and that leads to some slightly different hormonal profiles between these two classes of drugs. My colleague here at McMaster, Jonathan Pinthas, did some research over 10 years ago now, where he took rodents and he exposed some of them to nothing. So these are the control rodents. He did a surgical castration, an orchiectomy on some of the rodents. On some of them, he administered a GnRH agonist, leuprolide, and some he administered the GnRH antagonist, degarelix. Now, these columns represent how much plaque, how much cholesterol buildup he found in the blood vessels in these rodents. And interestingly, what you can see is that compared with the control rodents who had nothing done to them, those who had surgical castration or leuprolide had about double, at least double, in fact, the burden of plaque developing in their blood vessels compared to control rodents. But the group that received degarelix, the GnRH antagonist, did not have the same burden of plaque developing in their aortas, which is quite an interesting finding. And I guess one of the very first findings that suggested that maybe the GnRH antagonist offers some cardiovascular advantages over the GnRH agonists. Since then, there have been a number of trials comparing these GnRH antagonists versus leuprolide and other GnRH agonists. What we did a few years ago now is analyzed all of these human trials now, we're not talking about rodents, comparing these two strategies. Now, what these numbers represent is that if you were treated in these randomized trials with the GnRH antagonist, so in this case, degarelix, there was about a 50% lower incidence of cardiovascular events and cardiovascular death as compared to those patients who were randomly allocated to get a GnRH agonist. That's a substantially lower incidence of cardiovascular deaths and cardiovascular events in people getting a GnRH antagonist. So these kind of findings, have prompted a lot of research and a lot of interest, and people asking the question, should we all be using GnRH antagonists to treat people, especially to prevent cardiovascular disease from happening? Well, the FDA does not think so necessarily, and we also had significant reservations. Because when you look at, I guess, the quality and the robustness of these trials I showed you on the previous slide, you can see a lot of question marks, you can see a lot of minus signs here, and these tell us that in our scientific judgment, these trials were methodologically not adequate for us to conclude for sure that the GnRH antagonists are better at preventing, if you like, cardiovascular disease than the GnRH agonists. And so at this time, we don't necessarily recommend a GnRH antagonist purely for the purposes of reducing cardiovascular risk, but I think it's something that, we could discuss certainly after the presentation's over. There have been a number of trials since then that have at least got started to try and address this question definitively, more robust, methodologically rigorous trials. This was a trial that I served on the Data Safety Monitoring Committee for called Pronounce. This was a well-done trial in that they took patients with cardiovascular disease already known. They were one of the 1 in 5 I mentioned at the outset who already had cardiovascular disease, but who had an indication for androgen deprivation therapy. And they randomized folks. What they did, though, was all of the participants had to see a physician who would pay attention to the risk factors that I showed you before that are generally not well controlled. In this trial, they were because of the study protocol. Participants were randomized to getting degarelix, the GnRH antagonist, or leuprolide, and they were followed up for 12 months to count literally how many died, how many had a myocardial infarction or heart attack, and how many had a stroke. Unfortunately, because of a number of reasons like slow recruitment, the sponsor decided to close enrollment of the study when not quite 2/3 of the target number of participants had been recruited. And at the end of this trial, 15 people in one group and 11 at the other had suffered one of those cardiovascular events or death. And so scientifically, these are not enough numbers to be able to lead to any strong conclusion about whether degarelix was better, worse, or the same as leuprolide, which was disappointing. There have been other attempts to address this since then. Some of you might be aware of relugolix. There was a trial again that I served on the steering committee for, and unfortunately, the company sponsoring that trial was bought by another company, and the new company decided not to continue with the trial. So we remain frustrated and suboptimally informed, but we are continuing to work on trials to prove one way or the other whether GnRH antagonists are going to offer a cardiovascular advantage. I mentioned a little while ago about the newer androgen receptor pathway inhibitors that many of you will have heard of. These two, in population data and in clinical trials, have been associated certainly with an excess risk of high blood pressure, maybe enzalutamide more prominently than abiraterone. And they've also been associated with fluid retention, and this can be a hallmark of heart failure, which I've mentioned before as well. So if there is a need for these more advanced or newer generation androgen receptor pathway inhibitors, the risk of developing high blood pressure and fluid retention is cumulative. It's on top of any risk that's already conferred by being on a GnRH agonist or antagonist. And in fact, if you look at population data, so this is again data from Sweden, looking at the risk of developing cardiovascular disease if you're treated with abiraterone or enzalutamide, there was a 10 to 20% higher risk during 3 years of follow-up compared to patients who did not need abiraterone or enzalutamide. So again, these drugs probably add additional cardiovascular risk on top of what already exists and might already be conferred by, I guess, standard or starting point androgen deprivation therapy. So what are we doing to address these cardiovascular risk factors? One challenge I hear about a lot from my urologic colleagues is that they just don't have the capacity and sometimes the expertise to be addressing cardiovascular risk factors and disease in their patients. And not everyone has access to a cardiologist or a cardio-oncology clinic. And so, what we have been thinking about a lot is empowering patients to understand, much as you are today, their cardiovascular risk and what can be done about it. We're in the latter stages of developing and piloting an application that can be accessed on the web, on the internet, can also be accessed from a smartphone, where you, as the individual, can enter your data like your body weight, your blood pressure. If you have cholesterol numbers, you can enter those. And this app will calculate what your cardiovascular risk is thought to be over the next 10 years. And you'll remember before that, as I said, if you've got more than 20% 10-year risk, that's high risk. And certainly you'd want that ideally to be certainly less than 10%, ideally less than 7.5% risk over the next 10 years. Based on the estimated risk of cardiovascular disease occurring, the app then will provide guideline-based recommendations about what could be done to reduce that risk. And so we hope that this kind of app can become available and soon, so that it empowers individuals to be informed at least and to seek out appropriate strategies. After we complete this pilot testing, and this is done in collaboration with my friends at the University of Pennsylvania, we hope to do a trial to see whether using an app like this actually improves things for individuals. And so hopefully we'll be able to report back in a few years with more information there. This is what the app looks like, just if you're curious, the sort of information that's getting collected. And this tells, it's a kind of a graphic representation of what the risk is like and what the recommendations might be after that. I see a question in the chat, and I'm going to get to those questions perhaps towards the end. Another important thing to bear in mind is that androgen deprivation therapy is, not just linked with cardiovascular risk factors and cardiovascular disease. There are other factors that may be involved. Depression is certainly a risk factor for some cardiovascular events. And in fact, we find in our cohort that it's a risk factor for actual death as well. And so we are doing more research to understand the interplay between depression, androgen deprivation therapy, adverse clinical outcomes like death, cardiovascular disease. And so this is an area of active interest for us. And again, perhaps we'll be able to share more information on this in a couple of years' time. So what happens if you do have significant cardiovascular disease, but you also have advanced prostate cancer? Should treatment recommendations differ compared to somebody who does not have prostate cancer? Well, it's a difficult question to answer. We don't have a lot of research to inform us who, with an advanced cancer, be it prostate or otherwise, is likely to benefit from some of the cardiovascular treatments, especially the surgical treatments we have available to us in the left-hand side of this schematic here. What we've proposed is this kind of working framework whereby on the top axis, and the top, a row, the more advanced your prostate cancer is, the more likely you are to die from that cancer during the ensuing years. And so arguably, the less benefit you are likely to see from various cardiovascular interventions. Whereas if you have newly diagnosed cancer, even if it's newly diagnosed metastatic prostate cancer, as you know, the outlook is not, one of an imminently poor outcome. With all of the treatments that are available, folks will live with metastatic prostate cancer on average for years. And so they should certainly not be denied or not considered for a number of cardiovascular interventions. And those interventions are also graded. So some interventions from a cardiac perspective give the patient benefit immediately and dramatically. A typical example being if you have an acute myocardial infarction, so a heart attack, and you go to emergency, if you get prompt treatment for that, that will firstly alleviate symptoms. Secondly, it will significantly reduce the chances of dying of cardiovascular disease. And we don't, we think that that's a treatment that should be offered to the vast majority of folks with prostate cancer. Perhaps the only exception being somebody who says that, they're really in a palliative stage and any sorts of interventions are not consistent with their goals of care. If you move down the column on the left, though, and we look at more and more invasive procedures that have longer rehab times, higher complication rates, things like coronary artery bypass surgery, implantable defibrillators to prevent cardiac death. Some of these may take years before any overall or average benefits are seen for patients. And so I think that the time scale of the benefits that these procedures offer needs to be taken into consideration when you, as a patient or healthcare providers, are considering the appropriateness of these for folks with an advanced cancer. The decision making is complicated. And again, we propose this kind of a framework to summarize the sort of factors that we feel should be taken into account if there is a compelling reason for you to have an invasive cardiac procedure, but you also have a cancer that's undergoing active treatment. Obviously, the cancer characteristics are important. If, as I mentioned before, it's advanced metastatic disease, perhaps castrate resistant with widespread metastases, that's going to have a different a set of considerations to somebody with newly diagnosed localized prostate cancer. The severity of the cardiovascular disease obviously is a factor, and how symptomatic it is, as do comorbidities. They matter as well. Of course, perhaps most important, and maybe I should have put that at the top of the slide, are the individual's goals of care. If palliation is really the goal of care, then invasive cardiac procedures may not be a strategy that is desirable. The potential for some of these procedures to interrupt cancer therapy. We've got cases of patients where prostatectomy is recommended, but who also have an indication to have coronary artery bypass surgery. So we get asked, which should happen first, the bypass surgery or the prostatectomy? And in some cases, it actually changes the management decision-making for the prostate cancer treatment. In one case, I can recall, from a prostatectomy to radiotherapy. And thrombocytopenia, low platelet count, not so much of an issue with most prostate cancer cases, but with some chemotherapies can certainly cause low platelet counts, and that can predispose to bleeding. And of course, from a cardiologist perspective, we often prescribe blood thinners to treat many of the cardiovascular complications and issues. So these are the sorts of considerations that we make on a day-to-day basis when we are seeing people who could have a cardiovascular intervention, but also have active prostate cancer treatments. Many of you will have heard of these drugs called GLP-1 receptor agonists, perhaps Ozempic, Wegovy being the most commonly used. Of course, they gained a lot of attention because many people, especially in Hollywood, might use these drugs because they help people to lose weight. They're of great interest to us at the moment in folks with prostate cancer, especially those getting treated with androgen deprivation therapy. Because as you remember, I've shown you that androgen deprivation therapy leads to higher rates of adiposity, weight gain, leads to diabetes and high blood pressure. These drugs, these GLP-1 receptor agonists, have proven to be remarkable drugs because they help control diabetes, and that's what they were designed to do. But when they developed these drugs, they noticed that they also led to quite significant reductions in weight. And with that came reductions in blood pressure. And with all of those came reductions in the risk of developing a cardiovascular event. And so it's now been very categorically proven that these GLP-1 receptor agonists in individuals with diabetes and cardiovascular risk factors, or overweight, obesity, and cardiovascular risk factors, are excellent drugs at preventing cardiovascular events from occurring. So, given what we know about the side effects of hormonal therapy and the positive effects of these drugs, a question we've been thinking about a lot is, should we use these GLP-1 receptor agonists, if you like, as an antidote to the side effects of androgen deprivation therapy. It might seem appealing, hasn't been systematically tested or evaluated. And importantly, in red, I've highlighted one of the other effects of both androgen deprivation therapy and the GLP-1 receptor agonists, and that is a loss of lean body mass. And by lean body mass, I mean muscle. So we know, as I've shown you, that androgen deprivation therapy reduces muscle strength by about a quarter. We also know from emerging research that these drugs, these GLP-1 receptor agonists, do lead to a reduction in muscle bulk and muscle strength. So the question then is that combined effect on muscle of a GLP-1 receptor agonist plus hormonal therapy something that we really need to be concerned about? Is that going to cause safety issues that negate the benefit that you see in terms of weight loss and adiposity and cardiovascular risk factors? We don't know is the short answer, and we're doing more research to try and find what that answer is. What I can show you, though, is the experience of patients from the general population, in this case from England, who have diabetes and get treated with either one of these GLP-1 receptor agonists here in the bottom left graph, versus a more traditional or older diabetes drug called a sulfonylurea. These curves represent the accumulation of new prostate cancer over time. So all these individuals at the beginning did not have prostate cancer. They were followed up, you can see on the horizontal axis here, up to 12 years. And you can see that new prostate cancers accumulate over time. And the percentage of the people who develop prostate cancer is shown in the vertical axis. So what's interesting is that if you go out to, say, 10 years, this solid black curve here, about 2.5%, 3% of individuals in the United Kingdom at 10 years have developed prostate cancer if they've got diabetes and are treated with a sulfonylurea. If you look at those who got treated with Ozempic, essentially, at 10 years, the number who developed prostate cancer was lower than that. It was about 1.5%. So it's a really interesting signal raising the question, is there something about these new drugs, the GLP-1 receptor agonists, that leads to less prostate cancer developing in the general population? To prove that this wasn't a fluke, folks from Scandinavia did the same kind of study. Here, looking at diabetic patients in the general population and the accumulation of new prostate cancer over 10, 12 years in those who were treated with insulin for their diabetes in the top line versus semaglutide or GLP-1 receptor agonists on the bottom line. And you can see, again, a clear difference where those treated with insulin develop prostate cancer more frequently than those treated with a GLP-1 receptor agonist. So again, really interesting preliminary data. Why can't we take that as evidence that GLP-1 receptor agonists prevent prostate cancer? It comes down to research methodology. These were non-randomized trials, meaning that you got whatever drug you and your physician agreed upon. And there may have been factors that were linked to the GLP-1 receptor agonist prescription that were also linked with a lower risk individual for developing prostate cancer in the first place. So in and of itself, even though these graphs, might look impressive, the difference looks impressive, not enough for us to be able to say for sure that GLP-1 receptor agonists lead to less prostate cancer than other diabetes medications. We looked, and we presented this at ASCO GU this year, at 58 randomized trials now of the GLP-1 receptor agonist. So these were clinical trials where an experiment was done. The patient with diabetes or obesity was randomly allocated either the GLP-1 receptor agonist or a placebo or sometimes an active diabetes medication. We found that there was a 14%, that's what that 0.86 means. So 14% lower than 100%. So 14% lower risk of developing new prostate cancer in these patients who are randomly allocated to get a GLP-1 receptor agonist as compared with another diabetes drug or a placebo. But what's important was this was not robust enough to achieve what we call statistical significance. Because basically, the occurrence of prostate cancer in a general diabetes or obesity population just wasn't frequent enough for enough new prostate cancers to be diagnosed for us to be certain about this estimate. And so while the number looks interesting and possibly suggestive, we really need more research to know whether GLP-1 receptor agonists lead to less new prostate cancers developing than other diabetes drugs, or in fact, no drug at all. And so that is exactly what we want to do. Well, almost. What we want to do is actually extend or extrapolate this kind of information to determine what effects the GLP-1 receptor agonists have on the prostate cancer, among other things, in people with known or established diagnosed prostate cancer. So what we've done is we have received an award from McMaster University and Hamilton Health Sciences to start with 20 patients who are treated with androgen deprivation therapy and administer a subcutaneous semaglutide to them in a clinical research setting where we are going to measure their PSA levels. We're going to be measuring, obviously, their physical measurements that I've spoken to before. And we're also going to understand how well the GLP-1 receptor agonists are tolerated and how safe they are in these 20 individuals. Now, there are many men, many of my patients have already been prescribed GLP-1 receptor agonists who have prostate cancer, but we're going to do this in a research context. So we're going to measure exactly what happens after they start the GLP-1 receptor agonists. Along with that, we're going to start a randomized trial where this is just 50 patients. So it's just a vanguard phase of our clinical trial. But we're going to randomly allocate 50 individuals with prostate cancer getting androgen deprivation therapy to getting oral semaglutide, so the tablet version of semaglutide, or a placebo. And this is the best way of contrasting differences contrasting differences in weight loss, in PSA levels, in physical measurements, to know exactly what kind of an effect semaglutide has on individuals is only when we do it in a randomized trial and compare it with a control. And so that's what we're going to be doing over the next couple of years. Our hope is that we can derive enough information, enough evidence to compel funding organizations, be it the NIH, and that may be challenging in the current environment, or other funding organizations, to test whether the GLP-1 receptor agonists have effects that could lead to improvements in not just obesity and blood pressure and cardiovascular disease, but actual improvements in prostate cancer risk and levels compared to not receiving one of these drugs. So that is the note I wanted to end on, because I think that's probably where the state of the art is in the work that I do. And happy to take any questions about this or anything else we've talked about.
Hey, let's see. Darryl, thank you for your presentation. Let me remind you that actually most of the audience are men with lower risk prostate cancer. So I wonder if you could address the cardiovascular concerns in this population. Your study, and I can understand why, in looking at ADT, is looking at the GLP-1s, but why not for guys like us? I mean, just from personal experience, I can say 20 years ago, I had a widowmaker heart attack. I walked away, I was fine. But 5 years after that, I got diagnosed with prostate cancer. 5 years after that, I got diagnosed with type 2 diabetes. So, and I think there's probably a lot of other guys in this audience who probably have had similar experience. I've known a lot of guys like this. So, what should be our concerns, and when do we get our Wegovy?
It is exactly the same, Howard. I mean, I would say that androgen deprivation therapy only kind of accelerates what is already happening, as I showed in some of the very early slides, in terms of cardiovascular risk. Androgen deprivation therapy only kind of accelerates that. It doesn't mean that if you are not getting androgen deprivation therapy, you're immune, or, as you know very well, that you are not susceptible to cardiovascular disease and cardiovascular risk. So the question about when should you be getting Wegovy? At the present time, it's approved for folks, with diabetes. It's approved for folks with overweight, obesity, especially with cardiovascular risk factors or cardiovascular disease. And that applies no matter who you are, whether you receive androgen deprivation therapy or not. These drugs to date have proven to be really useful drugs. And so then it becomes a question of cost, because certainly in Canada, so north of the border, we pay about $800 a month for these drugs. They're not cheap. And so, can we as societies, can insurers, can individuals afford to pay for these drugs? Is the next question. At this time, very difficult. But I believe the first generic version of one of the GLP-1 receptor agonists, the generic version of liraglutide, just got approved in the United States. So over time, the cost of these drugs will come down and they're going to be more accessible. When they do, I think they're going to be a great innovation for a lot of people. Much in the same way as I'm sure there are many of you on statins now. And that, back in the day, was a great innovation. And that has led to, as one of the reasons, it's led to a substantial reduction in the number of people dying or developing cardiovascular disease in the last sort of 10 to 20 years. So I think this is, as with all new technologies, an evolving space. When they become cheaper and more widely available, more people are going to benefit from them until, I think we're going to find that, like statins, they're almost par for the course for many older men.
Let me ask you, there's been a lot of excitement about the Wegovy thing, but there's a lot of downsides to it too, right? I mean, it's not exactly a free ride.
Well, the main downside in my patients and in the clinical trials is that it causes things like stomach upset, gastrointestinal upset. People feel early satiety, they feel bloated, uncomfortable, they go off their food, they lose their appetite. Here's the catch, the kicker. You can't lose weight without losing your appetite, you know? It's part of the reason why it works. It makes you feel satiated more easily. So, that is really by far and away the most common side effect that patients notice. I've prescribed this to dozens of my patients, and the overwhelming sort of response to it has been positive. People feel so much better when they're carrying around pounds and pounds less of weight. They can do more, they feel more active. And I say this, and among my disclosures, none of the companies that produce any of these GLP-1 receptor agonists supports me or my research. So this is an unbiased opinion here. But in my mind, in general, the benefits of these drugs would appear to outweigh the side effects for the large majority of people.
Gotcha. I'm going to ask one more question, then I'll turn it over to Jeff, and Jeff can turn it over to David, who've been monitoring this. So I can remember when I started with the prostate cancer that I was doing some monitoring with C-reactive protein test, to test for inflammation. But it's funny, I had to bring it up to the urologist. And I wonder, for a general audience of men with prostate cancer like this, especially low risk prostate cancer, should we be getting C-reactive protein testing or other indicators of heart disease?
Yeah, so folks are aware C-reactive protein is a measure of inflammation. And you can get elevated levels of C-reactive protein, so inflammation from a lot of things. You can get it from having a common cold, a virus, any other illness, various types of arthritis. Whatever the reason, there was a study led by Paul Ridker from Harvard some years ago now, where he took patients with an elevated C-reactive protein level and randomly allocated them to getting a statin or placebo, and showed that in people with elevated C-reactive protein, a statin reduces the risk of developing a heart attack, stroke, or cardiac death in over a few years of follow-up. So a C-reactive protein is one of several blood tests and markers that can be done to identify people who might benefit from a statin. At the very least, I don't routinely order C-reactive protein, I have to say, but it's one option. What I certainly do order a lot of is cholesterol levels and measure a lot of blood pressures and calculate a lot of risk scores um, to determine, who I would advocate should get a statin. As it turns out, most people who are older men, will fall into that category where they're likely to benefit from a statin. So, that is a strategy that I think is really important. Blood pressure control is another one, which is always underappreciated. And we've shown that in our data that it's often undertreated.
Gotcha. Jeff, do you want to dive in?
Yes, yes, thank you. Good morning to everybody. By the way, I'm going to focus on questions just pertinent to today. I know there's some other questions about biopsies and that, and perhaps later we can cover those. The first question I have is from Jim Sims of Florida, lovely Florida. Are there statistics associated with low volume, low grade, non-aggressive Gleason 6 patients who have not had ADT and their connections, if any, to cardiovascular disease, doctor?
I think that our study might be the only one that's going to be able to evaluate it. We are still following individuals up, so I don't have that answer for you today. Our study is scheduled to complete in probably mid to late 2026. We have applied for funding to continue to follow individuals up to 2028, 29. But during this time, we hope to have an answer for you about that question, whether folks with, Gleason 6 prostate cancer are at lower, higher, or the same risk as anyone else with prostate cancer. That's something that we will be able to answer, not quite yet. And I think that our study is probably the only one that's well equipped to do that.
Thank you, doctor. Second question comes from Vernon Ramsey. Vernon asked, many medical studies, particularly with African American and African males, start with populations that are too small where the risk factors are skewed due to late study enrollment. Outcomes for many non-white groups are often worse because there is a lack of studies. The studies are not inclusive. Some difference in response rate and treatment are not considered. Would you care to comment, doctor, on this gentleman's inquiry?
Yeah, it's a great point. We noticed this in Canada. We have a smaller proportion of our population of African American descent compared to the United States. So we recognize this as a problem because we didn't have enough participants in our research who are African American. So that's why we collaborate with folks in Augusta, University of Pennsylvania, a number of other institutions across the US, in Texas as well, to try and enrich our cohort for African American patients with prostate cancer. It's still not likely to be enough. I think more research needs to be done to understand racial differences and nuances. In kind of unrelated work, this is in lymphoma patients. I collaborate with, again, my friends at Harvard to study the same sorts of questions specifically in an African American population. There are challenges, as many of you will appreciate, with, I guess, the current administration's stance on DEI research. To the extent that this is important for visible minorities, we need to just push on and do the best we can to try to get some specific answers to inform people who are African American, because we don't know whether what we observe in predominantly white populations is going to be equal and can be extrapolated. We have to do the research and the science.
Thank you. Thank you, doctor. Another question is there a relationship between the PSA and blood biomarker testings?
Which blood biomarkers are you talking about?
Just general, I guess they would say, shall we go to cholesterol? Should we go to sugar? Are there any things that show any kind of a correlation there between all those blood tests that we use? For example, the ones that are focused on diabetes and the PSA, anything show up?
Yeah, there are very slightly higher rates of things like diabetes and cholesterol in folks with more aggressive or advanced prostate cancer. What we don't know is whether that's just because of the prostate cancer itself, or whether it's because, individuals with diabetes or high cholesterol are also a little more prone to be getting perhaps more aggressive prostate cancer. We do know, you'll be aware, that obesity has for a while been considered to be associated with more aggressive or higher risk prostate cancer. I think there's still some uncertainty about the nature of that relationship, but that's, I guess, a summary of what the science would tell us at the moment.
Thank you, doctor. My final question is maybe with a little humorous side. Are there any bedroom surprises with cardiovascular health and perhaps prostate cancer?
Yeah, I mean, erectile dysfunction, obviously a big problem, for folks getting active treatments for prostate cancer. Erectile dysfunction, also a major indicator of vascular disease in the general population, the general male population. So, yes, erectile dysfunction is certainly something which might be an indicator that one's cardiovascular risk is high. And, it shouldn't be kept in the closet, so to speak. If you suffer from erectile dysfunction, then a physician should know about it because there's probably some work that needs to be done to figure out what's going on and why.
Well,
Along those lines, sorry, Howard, did you have a comment?
yeah, well, I was going to say, I was talking to a urologist about a similar question, and I was going to just throw this at you as well. He said in older men, it's less of a concern than in younger men as far as erectile dysfunction and a link with prostate cancer. Do you have anything to say about that?
Yeah, look, I think that's true. The prevalence of erectile dysfunction increases, I should say, as you get older, and so does cardiovascular disease. And so the signal tends to be a bit more of a wash in older individuals. I think that's fair and that's true. And of course, androgen deprivation therapy will give you erectile dysfunction, as will most interventions, for prostate cancer, like surgical interventions. So I think that's a fair comment. The other comment I wanted to make was for those of you who have been exposed to androgen deprivation therapy, vasomotor symptoms, so flushes, hot flashes, things of that nature, extremely common in people treated with androgen deprivation therapy. This is a big area of interest for us at the moment. Some of you might be aware that there is a drug that has been trialed and demonstrated to reduce hot flushes and these so-called vasomotor symptoms in postmenopausal women. Now we're starting to ask the question, well, would these drugs actually have the same benefits in men who essentially are andropause, post-andropause, just the male equivalent of postmenopause, and who have no testosterone levels? And so we hope that we'll be undertaking some research in the next couple of years to see if this new class of drugs is beneficial at reducing hot flushes. I can't say more on that at the moment because we're in the process of developing a proposal to do this trial. But I hope if I get invited back to speak with you again, perhaps in a couple of years, we'll be able to provide some more information there. So another vascular side effect of hormonal therapy that we hope to be able to address.
Thank you, doctor. I'm going to pass the baton over to my colleague, David Keller. Thank you very much.
Yes, hello, doctor. Thank you so much for your talk. I'm David Keller here in Jacksonville, Florida. And wow, beautiful, fantastic presentation, very enlightening. I've got a couple questions related in the statin LDL area and a couple others. But as a background, In terms of our group, I'll just speak for myself, but I think I speak for a lot of people in the audience. If you're going to do research with prostate patients in the future, we would recommend, and you probably already have included this, more than just the PSA as a marker. We would also recommend the prostate density index, the percent free PSA, and also I'd make a distinction. Some of us don't consider Gleason 6 as prostate cancer. And so if you call it prostate cancer, we're going to want to know if you're talking Gleason 7 or higher or Gleason 6. So we would appreciate that because we're making those kind of fine-tuned decisions within this kind of group as we monitor our prostate situation. One of the questions we had, I don't know if I can pronounce this word properly, colchicine. One gentleman wanted to know, are you familiar with that word? Oh, okay. Somebody wanted to know if that was helpful for prostate patients.
Yeah, so colchicine is one of the many types of anti-inflammatory that exists. It's been used for decades for folks with gout, for instance. Because it's an anti-inflammatory, and I mentioned C-reactive protein before as a marker of inflammation, people wondered whether colchicine was beneficial by reducing inflammation at reducing cardiovascular disease events. And so a number of trials have now been done of colchicine versus placebo, and they've shown that it does lead to reduced cardiovascular event rates. So yes, we do use colchicine in people with cardiovascular disease to prevent events from occurring again. It is not perhaps as widely used, let's say, as statins, drugs of that nature. And the reason is it hasn't been shown to reduce cardiovascular death is the first and foremost reason. So it might reduce non-fatal heart attack rates, for example, and the need for coronary stenting is another example, but hasn't been shown to reduce cardiovascular mortality. So that said, it is a drug that I use in some of my patients, where they've got refractory cardiovascular issues, and we're looking for something else that could help.
Wow, what a great answer. Thank you. I'm sure the person who asked that was very appreciative. I've had 3 or 4 related statin questions and LDL questions. Let me ask a foundational question. When you said C-reactive protein is being used as a measure of whether or not statin will help, are you saying if the C-reactive protein measure is considered higher than normal,
Yes.
then a statin might be beneficial?
Correct, yes.
Okay. Have you found that one particular type of statin is better than another for prostate cancer patients, for example?
Yeah, there hasn't been a great deal of head-to-head comparisons. What we do know is that if you use a high dose of a statin, that is better at reducing cardiovascular risk than a low dose. That has been tested and proven. But comparing one statin to another hasn't been shown so well. And so I tend to consider them one big family. And some people respond better or have more or less side effects to one statin compared to another. One other factor to consider sometimes is drug-drug interactions. That's always a consideration, especially if you're on multiple pharmaceuticals. And so that's one other factor that may play into our recommendations there.
Thank you so much for that. And high LDL is generally considered bad. Apparently, there's some research out there that says, no, don't worry about it that much. Should prostate cancer patients, as a rule, think, yes, high LDL is not good for us. We should, for any reason, but particular CV, we should think about lowering it.
That's an easy one. Yes, is the short answer. Absolutely.
I'm sure that gentleman was going to appreciate that. If someone already has metastatic prostate cancer, are they beyond help from a statin? Or if they've got high LDL, for example, if a statin is indicated, then regardless of the stage of your prostate cancer, would the statin be beneficial?
I think so. Look, if you get if I got diagnosed with metastatic prostate cancer tomorrow, I'm expecting to live another 5 years. And, during that time, there could well be a 10 higher % chance of me having a heart attack or a stroke. So I think that having a statin under those sort of circumstances is absolutely advisable. And with all the developments in prostate cancer treatments that are becoming available, if you want to benefit from these, you need to survive long enough to benefit from them.
Thank you so much. I just have one last question. you talk about the hand grip as being an indicator. I'm just wondering, when I go to the gym now, should I do hand grip exercises every day just to try and increase that strength?
I get asked that a lot. I don't think it's specific to hand grip. I think that
Okay.
we only use it because it's easy to implement, right? You can
Oh,
have
okay.
one of these, they cost about $200. We have them in the clinic.
Okay.
We don't have a fancy setup to test quadriceps strength, for example.
Okay.
So that's the only reason. But I would advocate that if you are at the gym, you not only do cardio, you do some resistance and strength training throughout, upper body, lower body, and core as well.
My last comment before I turn it back over to Howard. In our group, ASPE group, if you need volunteers, please come to us. I'm sure a lot of us would be happy to join in any of your clinical programs or your trials.
Thank you. Appreciate it.
Back to you, Howard.
Thanks, David. On occasion, we've had as a speaker one of your colleagues in Canada, Dr. Klotz, and he and others at some point kind of recommended a super pill, including aspirin, metformin, and statins. Is that a reasonable idea? Would you support something like that?
Here's the dirty truth.
That's all we want to hear every time is the lowdown.
The lowdown is that the pharmaceutical industry in North America will not pay for the development and regulatory costs for such a pill. They have in India, if you can believe that. So these so-called poly pills are not widely available, especially in North America, because they generally have not been developed, have not been approved, because it costs the pharmaceutical industry too much money to go through all of that process relative to what they can recoup through the cost of the drug. And that's a real shame because, as you say, if I had to take 5 different medications, I'd prefer it in one pill rather than 5 different pills. So that's where the current state of play is with the so-called poly pill. Some medications you'll see are combination pills. So some pharmaceutical companies have done it to a limited extent. For example, you can get Lipitor combined with amlodipine as a cholesterol and blood pressure combination, things of that nature. But combining 4 or 5 of them, it's not readily available, unfortunately.
Yeah, let me ask you specifically about low-dose aspirin. Has the status and recommendation of it changed? I was in a study. Basically, I had been told after my heart attack to be even before my heart attack, to be taking 2 low-dose aspirin a day. I guess 162 or whatever it is. Then I see a preventive cardiologist, and I was in a study at the University of Chicago looking at this. In the end, they recommended just taking 1. So is it 1? Is it 2? Does it matter?
Yeah, so if you have established vascular disease, so you've had bypass operations, stent, things of that nature, you pretty much always should be on aspirin, and 81 milligrams a day is the recommended dose. The reason 81, the baby dose, is that higher doses have not been proven more effective at preventing future heart attacks, but they will increase your risk of getting a stomach ulcer. So that's why 81 milligrams is the dose in people with vascular disease. The big question that is still argued about is whether it should be used in people who do not have vascular disease as a preventive. Essentially, to summarize the research, taking aspirin if you've never had cardiovascular issues will reduce your risk of a heart attack by 10%. Sounds great. Why wouldn't you? The problem is that it increases your risk of bleeding and stomach ulcers by a kind of commensurate amount. And so it does not reduce your chances of death. So for that reason, I don't routinely recommend people take aspirin as a preventive if they do not have vascular disease. I have an individualized conversation about somebody's risks and benefits. So for instance, if someone has low bleeding risk, but very high vascular risk, I might suggest they take an aspirin. If the converse, if they're at high risk of bleeding, for instance, they've got a history of ulcers or a bleed in the brain, and their cardiovascular risk is low, I would not advocate that they take aspirin as a preventive. So that is a more of a nuanced conversation nowadays, I would say.
Well, another part of the super pill is metformin. When I got diagnosed with type 2 diabetes, my urologist said, well, there could be a benefit from that, but I'm not sure that that's proved out, has it?
Really interesting question. I was on a symposium we organized yesterday, and one of the Stampede investigators was there. There will be data coming out this year at ASCO, I think he said, from Stampede, specifically on this question of metformin. I don't want to jump the gun and release what he told me because it was confidential.
Hey, well,
But
you're here with friends, Darryl. Come on.
let me put it this way. In the general non-prostate cancer population, there have been lots and lots and lots of trials of metformin to show that see whether it reduces heart attack risk, stroke risk, cancer risk, all things of that nature. It has never been proven to do so. It is a great diabetes medication at reducing sugar levels. Beyond that, in the general population, metformin has not been well proven to lead to any major benefits. As compared to the GLP-1 receptor agonist and the other big diabetic class of medications called SGLT2 inhibitors, like empagliflozin or Jardiance, drugs like that, those have been shown to reduce heart attack, stroke, heart failure risk. So as far as metformin goes, I think it's a fine drug, but I do not think it is as beneficial as a lot of the urologists seem to think it is. That answer is going to be revealed later this year.
Oh, okay. Well, we'll report on that too. Now, I was interested to see that part of your research is on frailty, and I'm going to make an assumption here that most of the guys here don't realize that frailty is a specific medical diagnosis. So I wonder if you could fill us in about that, and do you recommend going to see for primary care, like a geriatric specialist, and when should that happen?
Yeah, great question. This is one other big area of interest for me, research-wise. The problem with frailty is that there's so many ways to define it, dozens of ways. Broadly speaking, what frailty is from a research, a medical perspective, is it's some set of characteristics that is linked with a higher risk of dying if you develop a health condition, is the technical medical definition. What those characteristics are varies. Like I said, there are dozens of different frailty assessment tools that have been shown to predict your risk of dying. Perhaps the most widely used in research is a combination of the hand grip strength, the gait speed, so how fast you can walk, I mentioned that before. Unintentional weight loss is another important characteristic. Feeling exhausted, like subjectively within yourself, and low levels of physical activity. That's one of the more commonly used indicators of frailty. There are others. But the bottom line is that if you have below average strength, physical robustness, physical activity, your risk of death, your risk of developing diseases and dying if you develop those diseases is substantially higher. And we're not just talking about prostate cancer, no matter what, field, no matter what set of conditions, it appears to be true. So we've published fairly extensively on this, and a lot of people have. The several billion-dollar question is, what can we do about it? Obviously, exercise is a good thing, and we would advocate that at least 100 minutes a week for pretty much everybody. The challenge is, how do you get people to adhere to that, to stick to it? It's really difficult. Some people do, and that's great, but the large majority find it very difficult to exercise, get to a gym 4 or 5 times a week. Sure, there are exercises you can do at home, but again, sticking to it is very challenging. Are there other solutions that could be offered? Short answer is we haven't found any great and durable solutions yet. We're working on it. So again, this is going to take some time. I think the answer to this is further away than perhaps some of the answers for prostate cancer, but we hope to make some inroads scientifically there as well.
Let me ask you one last thing. And I don't know if well, let me ask you a goofy question. What's the difference? And this is not meant as a joke. What's the difference between an cardiologist versus a cardio-oncologist? Are they one and the same?
Yeah, no different. The term cardio-oncology was coined first really to describe cardiologists who have a particular interest in patients with a cancer or getting treated for cancer. And then someone pointed out that, we're not really oncologists. We don't treat the cancer itself. We treat the cardiovascular disease, and maybe it should be called oncocardiology. So that's where that disparity came from. Most people nowadays still call it cardio-oncology, even though I'm a cardiologist.
I gotcha. But okay, so, like the age group 75 and above, you know, should, when most of us are on active surveillance or some version of that, watchful waiting, should we stay on that till we reach 101? I mean, or when should we quit? Or should
With
we
active
quit?
surveillance, you mean?
Yeah.
That's a tough question, and it's a moving goalpost as well, right? Because as we get better at treating frailty, at treating cardiovascular diseases, etc., the threshold for getting definitive therapy, I think, is going to change. Similarly, even, hormonal androgen deprivation therapies is going to change, and it's going to be increasingly utilized. Um, and so, that's very much, I think, a decision that you need to make in consultation with your prostate cancer physician about when, enough is enough, and you just want to let nature take its course. So I can't answer that, unfortunately, Howard, but I think that it is a changing environment, and we're always developing new tools so that people can live longer and live better.
I
Let
had
me
a
ask.
question, Howard. Can I get a question in?
Yeah, well, you beat me to the punch there. I was hoping you'd jump in. And David,
Yeah.
if you've had some subsequent questions, why don't you dive in after that?
Well, thank you, Doctor, for not discussing tariffs. I'm formerly Canadian, by the way. Uh,
I'm trying to stay apolitical because I don't want to be held up at customs the next time I come to the US.
oh, no problem, sir. Yeah. Anyway, I was kind of wondering about, let's see now if I can remember if the old brain is going to work. Are there specific imaging tests for the heart that you recommend?
Um, the short answer is that if you have a high cardiovascular risk score, just based on your cholesterol, your blood pressure, your smoking, etc., but you have no cardiovascular symptoms, in general, we do not feel that imaging is necessary because that provides us enough information to I see Rich Sousa's question in the chat, enough information to recommend or not recommend the use of a statin. Some folks have advocated for scanning for calcium in the coronary arteries. You can do a coronary calcium scan. It's like a very abbreviated version of a CT scan of your heart. And that, researchers showed might add some additional predictive information to cholesterol levels and blood pressure, etc. That said, it has not been shown that, unlike C-reactive protein, doing a coronary calcium has not been proven to lead to changes in treatment that have, resulted in fewer heart attacks and strokes. So yes, coronary calcium scanning may give you an idea about risk, but there's no scientific proof yet that doing that is going to improve your likelihood of surviving without a heart attack. So we don't routinely recommend imaging. If you have symptoms, it's a different story. If you're getting chest pain, you feel, short of breath, your exercise levels are not what they used to be, then yes, various cardiac tests and imaging, being one of them, may well be indicated.
And so I'm fortunate to have Dr. Matthew Cooperberg out here in the West, and we stopped riding horses. Can you tell me, in particular, doctor said to me in one of my recent visits, he said a good heart lifestyle is a healthy prostate lifestyle. Would you expand on that?
Look, I think broadly speaking, that's true. We know less about why some folks develop prostate cancer. We know less about why some folks will develop more aggressive prostate cancers than we do cardiovascular disease. I would say that as a cardiologist, we are ahead in terms of research to understand the reasons why. I can tell you with a lot of certainty, we know we can explain between 50 and 70% of heart attacks we can kind of predict, we know are going to happen. That still leaves a substantial proportion that we can't predict, but that's not bad. Prostate cancer is less clear. I think the research about diet, about obesity, and prostate cancer risk, there's a lot more unknowns, I would say. Certainly family history, genetics appears to be an important factor there. But I think perhaps what your physician was getting at is, obesity and related issues are likely to be important factors. Certainly for cardiovascular disease, we know they're important, have been linked with more aggressive prostate cancer, but I think also obesity may pose problems for some treatments, prostatectomy, etc., in individuals who might be eligible for them. Obviously, the weight gain issue, if you're a candidate for hormonal therapy, is another factor. So obesity in general is a big thing, and that's why these GLP-1 receptor agonists are really important right now, and we need to understand how best to use them.
Thank you. And to be fair to one of our attendees today, he's asked some questions about needle biopsies. Would you care to comment on those?
Let me see here. A needle biopsy 3 years ago. Is that Jay Levine's question?
Yes, sir. Yes, sir.
Okay.
Robert.
I'm just reading it here. I'm not the person to answer that, Jay, I'm afraid. I am a cardiologist, as I said, and I'm going to have to leave that to a card-carrying oncologist.
Well, thank you, doctor.
Yeah, David, did you have something else?
A few more questions came in after we started, and if it's okay with Doctor, our speaker, to stick around a few more minutes, that would be great, and I'll ask the questions. One person asked about estrogen therapy. Was there some benefit to there in terms of the relationship between cardiovascular and prostate cancer?
It's a good question. There's been some recent renewed interest in whether estrogen is effective as a form of hormonal therapy for prostate cancer. We don't know enough yet about what effects, if any, that's going to have on the cardiovascular system. That research is too new. What I can tell you, I don't imagine too many folks with prostate cancer will be taking androgen supplements, but for the general population, the group led by Steve Nissen at the Cleveland Clinic did a 5,000 person trial of men with low testosterone levels, no prostate cancer. And they randomly allocated them to get testosterone replacement versus placebo. It was neutral when it came to overall cardiovascular death. So testosterone is neither here nor there. It doesn't increase the risk of cardiovascular death, doesn't decrease it either. There may have been an increased risk in some cardiac arrhythmias with testosterone. So I generally don't advocate, I do see patients who take testosterone. Some people, for aesthetic reasons, because they want to, they're bodybuilders, etc. And I would not advocate that. I don't think that's a sensible thing to do from the cardiac arrhythmia perspective. So I think that's really kind of where our understanding is about testosterone, estrogen, cardiovascular risk, is that they so far overall are fairly neutral.
Okay, thank you. I had a question. Can dutateride, if I'm pronouncing that correctly, to inhibit conversion of testosterone to dihydrotestosterone, can that be useful?
I mean, it as an form of androgen deprivation therapy, it's what I would describe as weak, because there are obviously lots of other ways that your body can produce androgens. And so in and of itself, and again, I'm going to caveat this by saying I'm not an oncologist. I don't see patients prescribed dutasteride alone as hormonal therapy. It's generally used for other reasons like treating prostate symptoms, etc.
Okay, the last question I had here, and I think you've kind of covered it, but this was specific. Is the HDL triglyceride ratio a good indicator of potential cardiovascular problems?
Yeah, this is a relatively new thing. We're increasingly thinking so, especially because there are treatments only again within the last few years that can specifically target triglycerides, for example. So because these have only been proven beneficial and developed in, the last sort of decade, they're less widely used than the statins, which have been around for many decades. But certainly if you've had a heart attack and your triglycerides are not where they should be, there's good research to suggest that pills like icosapent ether, which reduces triglycerides, are beneficial.
Thank you very much. Back to you, Howard.
Hey, I think I have one last question. I want to make sure the power doesn't go out. Okay. Sleep. You haven't talked about sleep. Why is sleep important? I've been reading about CPAP, and I read that it's preventive of heart attacks, that it's preventive of strokes, and what's the cardiovascular take on CPAP and sleep in general?
Yeah, I'll start with the second one first, actually, because that's really interesting. To the extent that folks who get hot flashes from androgen deprivation therapy, they always tell me they don't sleep well. We are hoping that these new drugs that we're developing to treat hot flushes will also improve sleep quality. And I think that would actually be a big thing for quality of life. We hope to be able to show that. For the story about CPAP and sleep apnea, obesity, I would say, is the most common cause of obstructive sleep apnea. And obesity, like we've shown, goes along with a whole bunch of cardiovascular risk factors like diabetes and high blood pressure. So it's really difficult to tease out what cardiovascular disease is caused by the obesity and diabetes and high blood pressure versus what is caused just by the fact that your airway blocks up at night when you sleep. For those kinds of reasons, the proof that just being on a CPAP machine alone, without treating obesity, without treating diabetes and blood pressure, is beneficial to your cardiovascular health is actually pretty limited. So I would say that being on CPAP if you have sleep apnea is fine, and it can certainly improve sleep quality and improve how you feel. But I think it is arguably more important to treat the underlying cause, which is the overweight and factors related to overweight.
Okay, well,
Okay.
I'm going to let you go unless there's some other questions.
Howard, I had one that was sent through the email. I want to be honest about it. It's from Mr. Quentin Kindeman. And he says that his urologist, he's had 2 biopsies, not to worry about prostate cancer, is slow growing, and hypertension will kill him before the prostate cancer can. His systolic is above 200 when in the stirrups. And the cardiologist has told him, stop seeing urologists, perhaps tongue in cheek. And his answer is, does he need a new urologist or a new cardiologist?
Well, perhaps what you could consider is a 24-hour ambulatory blood pressure machine.
Ooh.
So you can get referred for these, and they will measure your blood pressure hourly for 24 hours, day and night. And that will give you a more accurate picture of what your blood pressure is, I would say, than a measurement from someone in a white coat if your legs are up in stirrups, etc. So I think that is probably going to give you a fairer picture of whether you genuinely have high blood pressure or not.
Thank you, doctor. That's it, Howard.
Okay, well, I want to thank you again, Darryl, for coming by. I thought it was very informative. I hope most of us don't ever go to ADT, but some of us will. So that's the way it goes. Hope to have you back. And we have the scoop. We want scoops here, and I think that's about it. And I don't know if Mark or Bill want to stick around.
Yeah, why don't we stick around again, Darryl? Thank you on behalf of ASPI. Outstanding lecture.
Well, thanks for having me. I really appreciate it.